Our next panel is on pregnancy and childbirth, something that's been quite topical of late, particularly given some of the work that's been done globally, but also the Joe Duffy show, for some reason, is now one of the reasons that we can talk about pregnancy and childbirth. Obviously, a lot of this work has actually been going on for years, and we've got three people with us who've been talking about this for a lot longer than that. So we have Ruth Fletcher, who's at Queen Mary in London and is a senior medical law lecturer. We've Sinead Redmond, who's a childbirth rights activist and a reproductive rights activist, and it's kind of support, like kind of general, does it all. And we have Sarah Fitzgerald, who is a writer, an ILMI board member and disability rights activist, and a mum to Alison, who is 7. So with no further ado, we're just gonna get kicked off here. Do you wanna come up?
Okay. Thank you. Hello everyone. I would like to thank Maria for inviting me to talk here. I'm not really sure why I'm here, but anyway, my name is Sarah Fitzgerald. After Maria said that, I've been married to Alison, who is now 7 years old, but prior to having Alison, I never really gave having children very serious consideration, and it was only after I had her that I thought about what this was. I realized that many disabled mother role models in our society, like in advertisements for nappies or for never see a disabled mother figure. So I thought that part the reason why prior to getting married, I never really considered this, and after we got married, my husband and my husband had cerebral palsy as well. We discussed it, we decided, yes, we did want children, and we were very lucky in that regard. So I'm also to say that a lot of the media around disabled parents tend to be quite negative about focusing on the care of the child, social worker intervention, so on. So my doctor is very positive. I treated like any other patient, started taking folic acid, and then when I became pregnant, I myself self-referred to the physio and the occupational therapist, and what happened was we could say much for another. They were very knowledgeable about impairment and pregnancy. I found myself doing a lot of the homework and what I need and how that would affect me. But that was a positive thing because I got to lead my own care as such and decide what I need myself. And I got more personal assistance from Office CAL, who my local provider, which is great. And then, because I had this strategy issue, I started looking into shows, started plans, formulation trainings, all that just made my life a bit easier once the baby came. So, it's important to know before I get extremely depressing. Some of my experience was quite positive. We were advised to seek the advice of a social worker, and we did. And guess what he told us? That he had no concern about my ability to parent, which is great. I wanted a section because my own impairment was caused by complications of birth, so that was readily accommodated. I had access to OT and video. I got the extra PAs, and we were given our own private room in the hospital because both I had my wheelchair, I had my walker, I had a lot of equipment with me that wouldn't fit in a normal room. And then initially when I consulted the anesthetist, he was pretty adamant that I'd be knocked out for the birth. But after talking to him, we managed to arrange a final and meant that I was away for the birth of my baby. So that was a massive thing that was very positive that I listened to and that I got. So, however, I know from talking to people that I'm not alone in experiencing negativity surrounding my pregnancy and the birth of my child. Activities for all the serious cases as the first time disabled woman, which I can say later, because a lot of doctors are like, wow, this is better than been treated from a pregnant disabled woman before. And Claire says, no, I work for a pregnant woman, not a problem, not a phenomenon. Well, we were pretty much a phenomenon in treated as such during my whole pregnancy. And I just know that the best part of a successful mother is the ability to form tasks on age. So that's been why, was I be able to do that. So, yeah, I had my session, had my leg out. The breastfeeding, I hadn't planned to breastfeed, but I decided to because suddenly I developed anxiety over being separated from Alison, and I thought maybe if I breastfed, there's no physical way you could remove my child from my source of food. I wasn't taking stress anyway, so and today we went home. We're supposed to go home from the hospital. We were all packed up, ready to go, and the midwife came in. I was on my own with Alison, and she said, listen, we have concerns about your ability to care for your child. And we think you might be a danger to I thought she was fine. I wasn't supposed to be sick because she really could be a danger. It was the worst moment of my entire life. I don't think I've ever quite recovered from that. So, we go home, but we had to agree to a number of bare conditions icons. We insist, because insisted that I bought a thing and that I carried Alison and sitting around the house. That's not practical for me. I walk around my house, so we got booking straight to push it in. I kept breastfeeding, didn't want to put it on if I was at least 6 weeks taken. And then the puppy handler came every single month for 6 months. So it was pretty intense. And the legacy about this is that it took a long time to find the answer. Of course, I loved her so much more than anyone in life, but I was always afraid of her in case she was taken. But subsequently, I developed postnatal depression. It got really bad and culminated in me having to take time off work. But I felt that I couldn't go to the doctor because then I felt the part my ability to pay would be causing into question. But the ultimate impact of that is I knew when it does and I'm so lucky, but it was so painful that we decided to everything to me, and I'm happy. So, but I think it could have impacted on my decision to have more children. So, in 2013, we're in a documentary and somebody who which is a bit awkward because everything is quite wrong, but the positive side of that one is for two parents and the positive side we got really good feedback and that helps us to be more accepted as disabled parents as well. So my advice really quickly would be sensitive in your approach to language use, overacting. Remember the social model of disability rather than focusing on short-term impairment, focus instead on how mother and baby can be facilitated and assisted, enabling mother benefits both mother and baby. And mother knows best listen and be open to trying new ways of doing things. Thank you.
Thanks, Sarah. That was absolutely incredible, and I think really kind of hit home the extent of the social barriers that are being faced in terms of the medical profession and the biases that can be seen there, and also the impact that has. Next up, we have Sinead Redmond, who is going to be talking from her perspective as a birth rights activist. So.
Thanks, Maria. I recognise an awful lot of the faces in this room as a result of my work in the repeal campaign and the movement towards our bodily autonomy in this island for over the last 7 years or so. But it's also been about a year as a result since I did any talking in front of people, so I love it out of practice. Forgive me. As I mentioned, I was involved in the repeal campaign over the last 7 years, and my focus was really around continued pregnancy and birth for a lot of it. I have 2 daughters of my own. I had previously had an abortion, but that wasn't what pushed me to become involved in abortion rights, actually, it was when I was 6 months pregnant on my first daughter, who is now, she's now 6, and I haven't slept in about 7 years as a result. And the anti-choicery billboard campaign, Abortion Tears Her Life Apart, There's Always a Better Option, was launched. And through that, my own experiences of denial of bodily autonomy in pregnancy and birth, and my resultant, although I suppose it's difficult to kind of pick out where your impaired mental health first begins, I very much felt that mine was as a result of my anxiety throughout pregnancy and then subsequently having experienced birth trauma. And then after that, years and years of sleep deprivation definitely did not help. But I suppose I'd like to highlight as well that when I'm talking, much of my work has been around, my activism work has been around supporting women and trans people in parenting and birth who experience fragile mental health. And that can often be, as I said, as a result of pregnancy and birth. So, and not only in the area of mental health, but also in the area of physical health and physical disability. Sometimes our experience of pregnancy and birth can be what leads us to experience life as a person with disabilities, whereas that's not something that would have happened or how we would have experienced life before. That was certainly my own experience. And I know that in hindsight it can maybe be difficult to unpick where I began to, like you can see patterns more clearly maybe looking back, but when you are caring so intensely for someone else, for a newborn, and for a toddler, 6-year-old, I don't know when it stops, I'll report back. You lose the ability to prop yourself up in the way that you had before. As well when you have experienced denial of bodily autonomy, trauma in maternity services, the supports that you have around yourself, you move over to caring for your child. And so you become unstable and rocky as a result. And as Sarah has mentioned, the access to supports in your own journey in parenting and birth are not consistent, are not necessarily accessible for all women and trans people who are parenting, who are experiencing pregnancy and birth. And something that I've particularly seen is that women with pre-existing disabilities and medical conditions have extreme difficulty in having any kind of consistent approach around their pregnancy care and their birth care in their interactions with their existing medical team. I actually think there's a particular culture in maternity care of disregarding the patient in front of you, the person in front of you, that I don't think exists with the same consistency across other care specialities, particularly in Ireland. I know a lot of us work towards the removal of the Eighth Amendment, and I think that in some people there was a perception that the Eighth Amendment was the cause of our denial of bodily autonomy, of the misogyny within maternity care. I think it was a symptom. I think it was the expression, the real legal expression of how women were, and in some cases still are, viewed within the medical maternity model. Something that we also come across a lot is women who want to have access to a certain model of care. Sorry, I'm saying we, I really mean I and like the other activists that I've worked alongside in my kind of journey, lots of whom are in the room, is women who want to have access to a particular model of care, which is the maternity model of care, where birth is treated, pregnancy and birth are treated really as a normal part of life, not necessarily a medical emergency. And for women who have additional needs, women and trans people who have additional needs, disabilities maybe, that becomes more and more difficult to access. And for a lot of people, it's not because they necessarily don't want contact with doctors during their pregnancy or birth, it's because they want to be assured that they won't experience what are unnecessary interventions, unnecessary medicalisation, and what they perceive as a removal of their own voice and their own experience from the centering of their care. Often what we would have heard from doctors is the idea that they have two patients in the entire journey of pregnancy and birth. And I would argue that while of course there is the case of two concerns there, you have one patient, and it is my job to care for the person that I am carrying. It's my job to make decisions on their behalf. I want to hear what's going on with them, but I don't want you to think that you are the person caring for them. I want the information, and I want to then make my decisions accordingly, not have that taken out of my hands. In my second pregnancy, which was actually on paper looks far more worrying than my first pregnancy, because I had pulmonary embolisms in the 13th week of pregnancy. So what, in hindsight, was a near-death experience. I actually felt far more empowered in that pregnancy, despite the fact that it was much more difficult in many ways. So I was already experiencing mental frailty, I suppose, and a lack of ability to connect with support in a kind of realistic and consistent way in that, which is something that we see kind of consistently throughout that. I'd experienced physical debility from my first pregnancy kind of carrying on, which was only resolved after, again, finding private care, which is not something that you should need to buy your way out of, but nonetheless is the reality for many women, and many women and others during and after pregnancy. And again, comes back to what I mentioned earlier, which is how the experience of pregnancy and birth can lead you to experiencing life as a person with a disability when that wasn't your experience before. But my second pregnancy and birth, as I said, even though to someone assessing both of my experiences on paper, it looks as though it was a lot more traumatic and a lot more difficult, was for me much better as an experience. So I suppose what I want to highlight is that I think a lot of people assessing from the outside think you had this medical experience, you had this potentially dangerous occurrence, you had a more medicalised experience or birth that you thought you didn't want. But it's about how you are communicated with. It's about how you are put at the centre of your decision making. And of course, for people who live life with disabilities, that's the case all the way through. Your intersection with the state and your interactions with healthcare. But as I say, I feel that's intensified in the maternity services, where there is and always has been in the medical model a tradition of removing the voice of the person who's at the centre of being cared for, because there's an assumption that it's always an emergency or that the person providing the care always knows best. Now, I want to highlight that the working conditions in maternity services in Ireland, and therefore the conditions that we're being cared for, are absolutely horrific and are only getting worse. And I have intense concerns around that, because I think, as a lot of you will know, we experienced a huge amount of burnout in the aftermath of the referendum. I know I was only starting to come back to myself a couple of months ago, and I certainly wouldn't have been able to gather the energy to travel to Galway from home up until very recently. But I think things are getting rapidly worse within the maternity services in terms of staffing, in terms of facilities, in terms of funding facilities, and I have grave concerns around how long before it collapses in part or even completely. And because women and people with disabilities are at the most vulnerable, I think, within the system, I worry about the potential outcomes for us and for them within there. So that wasn't very hopeful, but I'm feeling mostly concern around the maternity services at this point and for where we are going. I don't think repeal is the panacea for the maternity services. I think a lot of people thought it would be. I never thought it was going to be. And I feel like we need to build for more of a push towards not accepting maternity services, maternity care provision, and our healthcare needs within that forever being at the bottom of the barrel. Thank you.
Thanks, brilliant, Sinead. That was brilliant. We're now going to have Ruth, who will talk from a more...
Work. Great. Hello, everyone. 2 tough acts to follow there. So fascinating to hear about the experience. And I guess at different levels, one of the things I want us to focus on, or I'm trying to think about, is just how we can use, the expertise from experience, how we can translate that into legal consciousness and hold law accountable to that. So that's one of the things I'm trying to think about with you all today. But so basically what I'm trying to, my brief is just to speak briefly about rights in pregnancy and childbirth then for adults with disabilities. And so following on from what's been said, because so much about law is everyday life, right? Our experience of law at the interface in medical services, and it's not just about in the courts or in the legislature, obviously, right? And so trying to think then about how we use both the potential and the limits of formal legal rights to address, some of the gaps in our protections in everyday life around childbirth and around pregnancy options. So that's how I'm thinking about rights then in that way, how to hold them to account and use them, I suppose, in order to try and address the gaps in our human rights in practice as well as on the books. And so in thinking about that then, basically, I just want to kind of focus, I suppose, on how then we can bring the consciousness of rights and the experience and expertise around childbirth and around pregnancy that we've heard about, how we can bring that to the legal protections as they sit at the moment in the context of pregnancy and childbirth in Ireland. And so, as everybody knows, there's a long legacy of not respecting women in pregnancy that precedes the Eighth Amendment, as Sinead said. And so that's the context in which we're working. But at the same time, we do have a right to refuse treatment as part of the doctrine of consent. And that has been formally recognised, as you'll all remember, in HSC against B. So in that case in 2016, which concerned an effort by the HSE to perform a C-section on a pregnant woman, as she was in labour, that is a good result in a sense, right? And so that's important, that decision in that context, that they decided, even though the Eighth Amendment was present, even though they assessed the right to life of the unborn, they decided that it was a step too far, basically, to compel a woman to undergo a C-section, even though she had a history of having had 3 C-sections, and the concern was that she would have uterine rupture, right? That there was a significant risk to her health and her life if she went ahead with a C-section in those circumstances. So it's all the medical evidence, right? And again, this is about over-medicalisation and challenging that. But a lot of the medical evidence that was given was that it was a significant risk, okay? So even though they kind of guesstimated the risk as a 1 in 10 risk of uterine rupture, and even though, that could have very significant consequences for her. Now, obviously, that's not the only thing that counts, right? We all know that she should be able to take on board that risk if that's something she chose. But the court actually supported her in that, even though we were in the shadow of the Eighth Amendment at that point. So that's something for us to hold on to, right? That right to refuse treatment as protected in that case. Now, there's obviously, though, the limitation of that is the uneven protection of that right to refuse treatment in the context of pregnancy, in the sense that it's dependent on capacity, right? That her capacity was challenged by the HSE in that case, her capacity to make decisions. And again, for our purposes, 2 of the interesting things then in thinking about it as the uneven protection of the right to refuse treatment is that the HSE sought to challenge her capacity on 2 grounds, right? One was that her doula exercised undue influence on her and her decision wasn't voluntary. So again, that's really important. They tried to say the decision of the pregnant woman wasn't a voluntary decision because of assistance. She was voluntary assistance that she was having. And they tried to characterize that as undue influence and vitiating her consent. So that's obviously one of the pressures, one of the things that happens in practice. And it's really important that in this decision, the court said, no, it wasn't, right? It was a voluntary decision and that assistance wasn't undue pressure. The second thing that's important about the capacity issues in that case is that there was a misunderstanding of what the risk of uterine rupture was, in the sense that she was reporting that it was a risk of 3% as distinct from a risk of about 10%. Now, these are not very evidence-based figures because the numbers of women who have C-sections in these contexts are tiny, and so we have to take those statistics with a grain of salt at one level. But the fact that there might have been a mistake in her understanding about what the doctor had said about the risk could have undermined a legal finding of capacity, but the court said it didn't in this case, or they didn't find that her capacity was undermined. Okay, so in that instance, we have a case which supports a right to refuse a C-section, that sort of intervention in pregnancy, and resists challenges in this context by the HSE to undermine her capacity. Okay, so there might be stuff we can do with that. But at the same time, we all know that there are lots of contexts in which capacity is challenged and has been found not to exist and is assumed not to exist in an everyday way. And so in moving towards implementing the Assisted Decision-Making Act and thinking about the test for capacity in that context, part of what we need to think about then is how the new test, the requirement of understanding, of using and weighing information, of communication, of retaining that information, how we evidence that, right? We shouldn't have to be the ones doing all the work of defending that, right? But again, that's something we can think about strategically in our peer groups, in our support groups, is how we evidence that women who are being challenged on capacity grounds in an everyday way, how they evidence that they have understood issues around fetal monitoring, issues around pregnancy health in general. And so that's something that's being contested, obviously, more. With the context then, the uneven protection is obviously in cases where capacity has been found to be lacking, right? And so in those contexts then, in that context, it's possible for the court to order. And so Eleanor brought up earlier, the fact that we have a lack of scrutiny as well, in the sense of wardship decisions not getting scrutinised, and that's one of the reasons why the project is so important. And so we don't have enough documentation, really, about some of these decisions. But we know, as Emma raised earlier, that there has been a decision, to perform a mastectomy on a woman who was living with schizophrenia and was found not to be capacitated. So in that context, there has been a significant imposition of a surgical intervention against her will. If we want to look to the Court of Protection in England, they have dealt with a number of cases where the authorities sought to a C-section against a woman's will in contexts where 3 or 4 of the cases relate to social disabilities, so women living with bipolar or schizoaffective disorder. There was 2 cases concerning women living with learning difficulties and autism. So in those sorts of cases, C-sections under the best interest test in the Court of Protection have been ordered against the wishes of the woman. So that's again partly the context that contributed to that we can work against, and we've been strategizing a bit about in response to these cases then, is that they were often very rushed cases, right? There's a lack of management of the birth plan, a lack of anticipation of how to accommodate the woman's wishes in managing pregnancy. And so we are seeing, we are seeing some progress in response to that now, in the sense that thinking about the sort of factors you both raised, the trauma of imposing an intervention like that, or a trauma of, poor birth experience, is being taken more seriously now in balancing the kinds of risks that have to be taken into consideration when making a best interest decision or a decision in those contexts. So that's something, right, that why this project is so important is in generating more legal consciousness, more experiential expertise around the consequences of these sorts of interventions for women in pregnancy and in childbirth. And if we can feed that into these decisions, hopefully we'll make some more progress in terms of reducing the coercive levels of law that are at risk of being imposed on women still and pregnant people in this context. So as we move, hopefully, through greater human rights protection and greater respect for people's wishes in these contexts and on the basis of evidence of experience, we're talking about moving more to a model of dialogue and thickening out, moving away from a negative conception of rights and just refusal of treatment to a more positive conception of rights that are supported and accessible in this context, and that involve dialogue and figuring out together what is possible. So that's the kind of shift, hopefully, we're trying to move towards. We're not there yet, obviously, away from just a thin right to refuse treatment, which is very uneven, towards a fuller, reproductive justice orientated model that involves dialogue and support. Okay, I'll leave it there. Thanks.
Thanks a million. That was brilliant, and I think from all three speakers we got a real kind of oversight of the multitude of ways law, policy, practice and attitudes go to erode disabled people in particular's own voice during pregnancy and childbirth. So we're going to open the floor up to questions. We have one there.